Welcome back, everybody. Just for those people who don't know me, my name's Nicola Mundy. I'm Child Wellbeing Professional Lead for Child Learning from Child Deaths, and I sit in the Child Death Review Partnership at Surrey Heartlands. Hopefully, people did manage to get away from their computers for those 15 minutes, because it is really important. I'm sure everyone had lots of emails coming in during the session. Just before we start again, I just wanted to reiterate that obviously this is a sensitive subject, and if anyone wants to chat to either myself or Nicola S. Basher at the end of the call or contact us, please do. At the end of the call, at the end of the training this morning, please do get in touch. Either by email or our phone numbers are on the end of our. I'll put them in the chat for people if anyone wants to give us a call. So now I'm going to hand over to Tim Woodhouse. Hopefully Tim's here.
Yes, I'm here. I'm here.
Yay, worked. And Tim's going to talk to us about his work around professional curiosity and domestic abuse related suicide. So if I hand over to you, Tim, to introduce yourself, is that okay?
Yeah, that's more than okay. I should be sharing my screen as
You
well
are.
now. Great. So let's put that on full, and I'm happy to take over.
Brilliant. Thanks, Tim.
So, yeah, thank you very much for the invitation to present to you guys all today. My name's Tim Woodhouse. I am from just down the road in Kent. And I am the Suicide Prevention Programme Manager there, and I'm going to talk to you today about some of the work that we've been leading over the last 6 or so years, really, in terms of our work to highlight the link between domestic abuse and suicide. I've done variations of this presentation quite a lot, so it's quite nice to actually be given a slightly different challenge and make it less around the domestic abuse suicide bit and more around the professional curiosity bit. So I'm quite excited to see how this goes. Apologies that I might not be quite as smooth as I normally am, but yes, I will add in little bits around our professional curiosity. Aiming to speak around for about 20 minutes, and then to have a little 20-minute discussion, and let me remind myself to start my stopwatch. And you can see on the screen, about what I'm going to do over the next 20 minutes, why we were curious on this issue, what we've managed to achieve, and then some thoughts about how you can be curious on this issue too. And then, as I say, 20-minute discussions. So please get your questions and comments and suggestions ready. We normally start this presentation by saying, look, we know enough to be seriously concerned, but we absolutely don't know everything. And so if you think that we're missing something, you've got an idea for something we should be taking forward or looking at in more detail, please let us know, because we are not claiming to be the experts in this at all. And as Nicola said, just the trigger warning, I guess, at the bottom, this is obviously a very sensitive subject, looking at two very sensitive subjects, domestic abuse and suicide. And we do have some quotes from some people in there, and which are not necessarily easy listening. So, who am I? Well, I am, as I've already said, the Suicide Prevention Programme Manager. I've been in the public health team at Kent County Council since 2014 and have been leading the suicide programme there since then. I'm also on the National Suicide Prevention Alliance steering group. The NSPA is a fantastic suicide prevention resource. It's free to join. So please, if you're not a member, either an individual or as an organisation, please join up, because it's a really great way of finding out what's going on in the suicide prevention world. And then, as you can see down at the bottom, I've undertaken 2 research fellowships over the last 12 months, both looking into the issue of domestic abuse related suicides, and both, as I guess, as a result of my own professional curiosity into this subject. as I say, we know enough to be seriously concerned, but we certainly don't know everything at this point, which is why I'm trying to do what I can to further my research skills in this area as well. So let's go back to 2018, and this is where it all started, really. A very simple question from my community safety manager, who leads the domestic homicide review process in Kent. And he came to me because there was a change in the DHR guidance. And DHRs, if people don't know, domestic homicide reviews, they are statutory multi-agency reviews when somebody is killed by their intimate partner or family member. But the guidance changed in 2018 to include deaths by suicide. And my community safety manager, this is not being rude in any way, it's a fact of life. He asked me how many domestic abuse suicides there are every year, and he asked me that purely from a budgetary position. These reviews cost money to undertake, and he wanted to know how much money he should be allocating to undertake these suicide related DHRs. My very naive answer was, oh, that's an interesting question. I don't know, but I'm sure it's very easy to find out. Let me go away and I'll come back to you in about 2 weeks. And that was 2018. So that's 6 years ago now, isn't it? And to be honest, I still can't give him a good answer nationally. I think we can give him an answer for Kent and Medway. But nationally, I don't think we can still answer that question. How many DA-related suicides are there every year? So what did we do in those 2 weeks? Well, and actually it was probably a bit more than that, because as soon as we started looking, we realized there was no easy answer. So I know this is a lot of detail on the slide. I'm not trying to, you don't need to read all of it, but we just take the fact away that we did some initial research. And when I keep saying we, my colleague Megan Abbott and Sophie Kemsley have been with me on this journey for all of those 6 years, certainly in Meg's case, and Meg did a lot of this initial research. We tried to use the data sources that were available to us. So we had a look at all of our DASH risk assessments. So DASH is a risk assessment tool used in the DA world, domestic abuse world. And we looked at all the charities and the providers and the police through the DASHs, and we found that 63% had talked about either being depressed or suicidal. It's a terrible question in the DASH risk assessment, and I'll come on to that much later. Doesn't really tell you, because if they answer yes to are you depressed or suicidal, well, what are they saying yes to? It's very difficult. I'm not going to go through all of these, but just understand that we tried to use our own available data and we couldn't come up with a good answer. Lots of unanswered questions at that point that you can see. And absolutely, but there was no conclusive answer to the simple question that you can see on the screen. So fast forward to 2021, and we had continued to try and get better data sources. You can see here that we had initiated a real-time suicide surveillance system with Kent Police. That was already flagging that quite a high proportion of our deaths by suicide had been amongst people impacted by domestic abuse, and we wanted to do a lot more detailed digging. We had a very simple question, tick box. Was this suicide impacted by DA? Yes, no, initially. Obviously, that's not good enough. So we then expanded our real-time suicide surveillance questions to include things like, were they victim or perpetrator? Was it historical abuse, or was it recent? If it was recent, was it within the last 24 hours, etc., etc. So it's a continuing improving system, that RTSS. And even back in 2021, we were talking about this nationally and regionally. We were trying to get other people to be aware and to undertake kind of joint research with us. And you can see down the very final one, even then we were talking about trying to get domestic abuse as a explicit priority with what we were calling then the 6th annual progress report. We've now had a full new national suicide prevention strategy published in 23. So yeah, fast forward to now, and I'm just going to run you through a little bit now about what we do know. And the picture from our real-time suicide surveillance is really somber, I think. we have had 243 domestic abuse related suicides in these kind of 5 or 6 years. That's 32%, which is much, much more than we had initially initially expected. And obviously, it's much more than our community safety manager can afford to do DHRs on. So we are not doing DHRs on anywhere near this number, although we are into well into double figures now of DA related suicides that have been conducted DHRs. So this is a staggering figure, 32, much higher than anyone expected. But anyone who knows anything about domestic abuse will know that that is absolutely, I mean, I talk about that it's very likely to be an underestimate here. That's me being a little bit cautious, because I could guarantee that that is definitely going to be an underestimate, because we know that domestic abuse is not reported, definitely not to the police very frequently, certainly not in 100% of cases. So that is absolutely an underestimate. And if that 32% figure is replicated across England, it would mean well over 1,600 suicides every year. Actually, I need to update this slide. It was based on last year's ONS data. We've now had new ONS data, and it's now, if that 32% figure is, it would mean over 1,800 suicides impacted by DA every year. Some of you will be thinking, what do we mean? I keep saying impacted by, what do we mean by that? Well, actually, we mean these kind of 4 main cohorts in mainly. So absolutely, we know that victims of domestic abuse are definitely dying by suicide. And you can see here quite an interesting gender split, more females, but only just. We definitely, as you would imagine, are seeing perpetrators dying by suicide. Not surprising at all, really, that far more male perpetrators are in this cohort. But then this third category is one that we, again, we're not anticipating. Really interesting to see that this cohort is, and these aren't my labels, by the way, these are police labels. So where the police know the individual as both a victim and a perpetrator, we've got quite a lot of, well, definitely men, but also quite a lot of women who are known to the police as both victim and perpetrator, and they are definitely dying by suicide. I talked about the various questions that we have added to our real-time suicide surveillance collection data. And this is just one of them. This isn't meant to be a quantitative presentation, so I'm not going to go through all the data in detail, but this is quite interesting because it shows the time frame of when the abuse was happening. So you can see there are some victims absolutely dying within 24 hours, dying within 12 months of being a DA victim. Same true for victims of perpetrators, and same true definitely for perpetrators. I think this bar chart here, or yeah, this bar in the middle here, of people who are known to the police as both victims and perpetrators who have suffered both recent and historical abuse, by far the biggest number of deaths by suicide are in that cohort. Definitely. So again, in terms of the things we don't know, this is definitely something that we don't know, and I'd love to kind of hear any thoughts about whether anyone's got any thoughts about what's going on in this group. I guess it kind of makes sense that these are probably the most complex of people if they're known to the police as both victims and perpetrators, and they've suffered recent and or been involved in both recent and historical abuse. They're the most chaotic cohort. So being professionally curious, we wanted to know how our data matched with other parts of the country, how it matches with other parts of the world. Very difficult to really know what's going on because not many other areas are counting in the same way. But there was a very good report from NCISH, National Confidential Inquiry, who are probably the most preeminent academics in the suicide prevention world. They highlighted that just within the middle-aged men cohort, which is obviously the biggest cohort of people who die by suicide, 7% of middle-aged men are victims of DA, and 10% of middle-aged men who die by suicide have been perpetrators, which is really an interesting finding because that is not, having been in the suicide space for 10 years, we often talk about middlemen, but we don't highlight the fact that actually a lot of these 10% of these middle-aged men who are dying are perpetrators of abuse. They're kind of ignored, and we don't really kind of cater anything towards them. From data from Victoria in Australia, this just came out a couple of weeks ago, and I'm really quite pleased to see it, not because of the loss of life, because that's extraordinarily high, so over 1,100 domestic abuse related suicides in Australia, but because they've got a much bigger sample size. So if you can remember, the sample size in Kent and Medway over the last 6 years was only about 700. In Australia, they've got a much bigger sample size of 4,790 total suicides, and they found that 25% of those have been impacted by DA. So it's not quite the same 32% as we are seeing in Kent and Medway, but it is still a substantial proportion of the total number of suicides, and it's kind of in the same ballpark as we're seeing in Kent and Medway. So the previous speaker talked about that imposter syndrome, and I've often thought over the last kind of 4 or 5 years of, like, are we getting this right? Am I just doing something wrong? Are we speaking about an issue that's not actually an issue? We must have got our methodology wrong, or it just seems too high and no one else is really taking it seriously. Thankfully, people are starting to take it seriously, and when they do, they're coming up with figures that are not too dissimilar to what we're finding in Kent and Medway. And the other thing that came out earlier this year was a National Police Chiefs Council. So this is a UK National Police Chiefs Council report, which highlighted that there were more suspected victim suicides following DA than there were intimate partner homicides. And just to put that a different way, in 2023, the person most likely to kill a victim of domestic abuse was themselves. And I think that is a staggering fact, and it's certainly not one that I had anticipated coming across when we started this work back in 2018. But we have now got the National Police Chiefs Council saying that taking your own life is a bigger risk for a victim of domestic abuse than being killed by your perpetrator. That, I think, is staggering, and I think that has huge implications for the domestic abuse sector, which quite understandably has to this point just looked at the risk of death from the perpetrator, or the risk of harm from perpetrator, and the whole sector is geared up quite understandably, and I'm not saying it should lessen in terms of reducing the focus on the risk of harm from the perpetrator, but in addition to that, we also need to be doing far much more around reducing the risk of suicide. Okay, so to understand a little bit more, because numbers are one thing, but in order to put interventions together, we wanted to understand a little bit more detail, a little bit more nuance about what was going on and why domestic abuse victims were taking their own lives. And so here are some quotes from people who have been victims and attempted to take their own lives.
I knew that he was going to kill me. So it wasn't a matter of choosing to die, just who was going to do it.
And this is obviously a horrific position to be in. You are so convinced that you're going to be murdered that actually it's a better scenario, a better outcome is to take your own life, because then at least you have some control over the manner of your death. Just a horrific position to be in. But actually it wasn't the same for everyone.
I thought I was worthless. Like I didn't deserve to be alive, and that everything they said was true. I was horrible, and that the only way out was for me to die.
So these people, this cohort, don't believe that they are going to be murdered, but actually they believe all the lies their perpetrator have told them. They believe that they're worthless. They believe they're a burden on society, a burden to their family. They're not loved by anyone, and just the world would be a better place without them. But then there is this third cohort.
You go into survival mode. You're hyper-vigilant. It's exhausting and tiring. I was sick of fighting. I was sick of surviving. I knew when I woke up that day I would attempt suicide.
So this cohort are not fearing they're going to be murdered. They're not believing the lies and coercive control, but they are just sick and tired of the abuse. they're living on edge, they're hyper vigilant all the time, they're just in survival mode, treading on eggshells, being abused in different ways for such a long time. They're just trapped and they just want the abuse to stop. But then there's another cohort. So those first 3 cohort all made their suicide attempt during the abuse. But we also know that many victims of domestic abuse are attempting to take their own lives long after the abuse stops.
I felt broken. I felt so many emotions: shame, hurt, fear, grief. I felt like damaged goods. I couldn't sleep at night. I was having flashbacks and he was on Tinder finding the next victim.
So that's just a quick look at some of the qualitative research that we've done, and I know it's quite depressing. So to be a bit more positive, the suicide prevention strategy, the National Suicide Prevention Strategy last year, did include domestic abuse as a high risk factor for the first time. We were really pleased that they have highlighted our work as part of the reason that they've included DA in the suicide prevention strategy. So that's hence the title of the presentation, if anyone was wondering. It's great to have been able to influence the national policy. Unfortunately, there was no new money, there was no new interventions, but they did provide a commitment to do further research. And that research is absolutely needed, because I think there's evidence gaps everywhere. As I've already highlighted, we certainly don't know enough. We don't know enough about the male victims. We don't know about this cohort, about people who are known as both victims and perpetrators. We don't have nationally consistent data. We have no idea really how things like ethnicity or religion or age or disability might impact someone's risk of suicide after being impacted by DA. Nor do we really understand the different types of abuse. Are people who are stalked more likely to take their own lives compared to people who have been subject to coercive control or financial abuse? We just don't know. The research has not been done. But again, we could be waiting forever to really find out everything. So my public health perspective, I want to try things now. And my Churchill Fellowship that I've been taking the last year has tried to highlight actions which I think we can take either nationally or locally to reduce DA-related suicides. The full report isn't quite out yet. I'm hoping to publish it in the next month or two. It's going to be called something like 101 Ways to Reduce DA-related Suicides, because I want to focus it on that idea that we can be doing something and we need to be doing something. And again, I'm not going to go through all of these, but just in the report, I highlight the different areas that I think we should and could be doing things better. So absolutely, we need to be supporting young people to recognise and value healthy relationships. And we absolutely need to improve the support for women and girls who are being abused, as well as men and boys who are being abused. Again, not going to go through these all of them, but I think just to highlight number 6, I think we need to provide better specialist bereavement support for families after they've lost someone to a DA-related suicide. The absolute, and sorry for my language, the absolute shit show that is left behind when somebody takes their own life in a DA-related suicide is incredible. And that the language I used was not mine. It was from a woman I was speaking to up in Scotland, who said that when her perpetrator died by suicide, her and her daughter were left in that state where the perpetrator's family and friends continued the abuse in many different ways. Financially, they tried to change the locks on the house. They tried to beat her up at one point, and all the financial abuse in terms of access to pensions. So it's just horrific. All of the time, the woman was left behind thinking, well, am I to blame for his suicide? Because that's what the suicide note said. Am I to blame for his death? Which, of course, she wasn't. Anyway, we've also got some, well, as I say, 101 different ways, and I'm not going to go through each 101 because I'm already over time at the moment. But I think just in terms of real practical things that you could do tomorrow, this afternoon, if you're working with someone impacted by a DA, I think you have to absolutely be asking them, are they thinking about suicide, and have they ever made a suicide attempt in their lives? Because if you don't know the answer to those two questions, then I don't think that you can do number two, which is to ensure that every single domestic abuse safety plan should include a section which considers how to keep victims safe from suicide. We know at the moment domestic abuse safety plans are focused almost entirely, I would say 100% of them, most of them are focused entirely on keeping the victim safe from the perpetrator. However, we know that more victims are dying by suicide than are being killed by their perpetrator. So that balance has to be evened out. And again, just to stress, I'm not asking for less resource, less focus to be brought on the perpetrator, because that needs to remain, and actually, if anything, the resources into keeping people safe from perpetrators need to be increased. But in addition to that, we also need to be doing things around suicide safety as well. Just a couple of others that I'd pick out here. I mean, the domestic abuse training is an easy one to put right, but it's not happening, I don't think, anywhere near enough. So I've highlighted in the university curriculums here, but I think it should be an ongoing training throughout people's professions. And you could equally say the same flipped around. I think that domestic abuse professionals need extensive suicide prevention and mental health training as well. And then, as you probably all already read, my big one in terms of nationally is that these are just my ideas. So all the previous 100 recommendations are just my thoughts. But actually, I'm very well aware that an issue this size, if we are losing 1,800 people a year to DA-related suicides, it's bigger than just me. It's bigger than my team. It's bigger than you guys on this call today. It has to be a national task force that really brings everyone together from loads of different angles to agree a national action plan. I'm just going to show you, I'm not going to talk to it, but I'm just going to show you what I've got put in the rest of the slides, which will be coming around to you later as a PDF. So if you want to kind of adapt your practices, your risk assessments in terms to include some of the questions I've talked about, then giving you some ideas there, giving you some thoughts about how to talk about suicide and what feeling suicidal can mean. But I will leave you with the fact that if you've not done suicide prevention training recently, there is really good 20-minute free to access Zero Suicide Alliance training available to anyone nationally. And I would recommend that you complete it as soon as possible if you've not done so recently. Okay, I will draw a breath and leave it there.
Thanks, Tim. I know, because I can see the chat, that there are just millions of questions for you. So we'll manage, if people want to put their hands up first, and then we could cover the ones in the chat. But it was really giving us loads to think about. Hannah, did you want to come in?
Hi, yes, thank you. That was really, really interesting, Tim. I work in the suicide prevention team in Wales at the moment, but I come from a domestic abuse background, and I just had some thoughts around the victim perpetrator stuff as you were talking, because Michael P. Johnson talks about different typologies of domestic abuse. Yeah. And to me, that makes sense, because if you've got the intimate terrorism typology, then you will have a controlling perpetrator, and that victim is more likely to suicide, as is the perpetrator. But when he also talks about violent resistance, and so you've got a victim of controlling behaviour then who is fighting back in self-defence. And I imagine that that's when police are getting reports of a victim who is becoming a perpetrator, but actually not, they're fighting back. Is that something that you've thought about as well?
Yes, absolutely. Definitely something I've thought about. And I spoke to somebody in America who has done a lot of work about this, particularly about kind of women who are those kind of fighting back type violent resistors that you talked about. And absolutely, their lives can be ruined and their whole history of being a victim can be kind of eliminated by the one time they fight back and the police are called and they are suddenly they're arrested. And just that one occasion means that the abuse that they've suffered for the last 20 years is kind of eliminated, because now they're known to the police as you're a domestic abuse perpetrator. And it can cause such a huge, we're not quite so bad in this country to make people pay for their own perpetrator programs, but the women are being forced to pay by court order over in the States. And then if you're trying to pay for a court ordered perpetrator program, as well as hold down a job, as well as sorting out your kids' responsibilities and childcare, as well as being primarily a victim of domestic abuse, you can understand why they're not feeling too great about the situation.
Yeah, thank you.
Thanks, Tim. Andy, do you want to come in next?
Yeah, I put something in the chat, but really what I was going to say follows very much on from what Hannah just said. Coming from a police perspective, obviously you're going from data from the police, but what needs to be remembered is just because someone's recorded as a perpetrator doesn't mean they are. When police attend a domestic incident, we are obliged to record the allegation that's made. So if a man alleges that the woman in the relationship is a perpetrator, doesn't mean she is, but we are obliged to record it, even if we subsequently discount it or don't accept that as genuine. So the data will be slightly skewed in that respect. Does that make sense, Tim?
Yeah, it absolutely does, and it just highlights the what I want to do next in my career, which is to undertake a PhD, which would allow me to investigate that data in a much more kind of detailed way and try and uncover that exactly that scenario. Because I would love to know of this cohort that we really simplistically label as both now. You're right, Andrew. Just how many of those are unfounded allegations? How many of those get through to convictions or even arrest? And it's that level of sophistication and nuance that we don't know at the moment.
Yeah, I mean, the other part I was going to say follows very much on from what Hannah just said, and it's dealing with retaliatory victims. I've seen it many times in practical scenarios, but also in DHRs, where a male offender will goad a woman into retaliating by hitting him, slapping him, throwing something at him. Then he phones the police and says, she's assaulted me.
Yeah.
And on the face of it, he's got injuries consistent with that. So the woman ends up getting arrested, even though she's a victim of a lot of hidden abuse that we often don't know about.
Yeah.
And in a sense, what he's doing is taking away that last line of safety, because what that does is say, you can't rely on the police anymore. They're going to listen to me. You're going to get arrested. So that the police are the only 24-hour agency who can provide that sort of immediate response, that safety response. And effectively what they're doing is taking that away and saying, you can't even have help. The police won't help you anymore. So it's all me. I've got control. And that's what we see that in quite a few DHRs.
Yeah, and I've got nothing to say to that other than it's just a horrific situation to be in, isn't it? And there's no easy answer. Going back to the first presentation, there's not going to be an easy answer to what is a very complex problem. Yeah,
indeed. So there's lots of other people want to speak. So
yes, sure.
I'll wind my neck in now.
No, thank you.
Thanks, Andy. Karen, did you want to go next?
Yeah, can you hear me?
Yeah. You want to introduce yourself as well? Sorry.
Yeah, so thanks. I work for Your Sanctuary. We are a DA charity in Surrey. So yeah, my feelings on it, especially I think in the last year or so, there's been a lot more dual allegations to back up what Andrew said. And sometimes it's very strategic. So we will get one come through the police referred to us and almost immediately it could be either way, but say the male then calls the helpline and then wants it to be recorded that he's rung and that he's the victim. And sometimes it's a picking apart, especially if it's a long relationship, because what can be said sometimes by professionals who perhaps don't understand DA is, oh, well, it's tit for tat and it's this and it's that. Well, no, there's always a survivor and a perpetrator. But sometimes it's unpicking that and finding out where it started, which isn't always easy. And we have something called a perpetrator protocol to try and unpick, and that's not 100% obviously, because it's on our analysis of the answers to that to work out who the perpetrator is. But I think this adds to the suicide, because if you've been a survivor for this long and suddenly the perpetrators claim something, and I've heard of this before where they claim something, the other one gets arrested, gets put on bail, can't go back to the house, can't see the children. That's a massive pressure. So not only now are they a perpetrator when they're not, they've had all these rights taken away. And I think a lot more training needs to be done. I think Andrew would agree with the police, because not everyone in the police understands DA. And it takes training to understand DA. So I think it is a very complex thing. We do have one of our colleagues here who does the DHRs here around suicide, and it's definitely increasing with DA. It is a big matter for suicide, and very complex. So those are my thoughts. The other thing I thought was one barrier and another reason might be immigration status. So we have a lot of mainly women, I would say, who ring up who don't speak the language. They then need an interpreter, and then they don't have immigration status to stay. And effectively, although there is something called an MVDAC, that isn't always suitable to keep them here and fund them for just a few months, with the potential of being sent back to somewhere they left years ago, when spousal visas are cancelled and things like that. And that can have an added stress. What are you going to do now? You can't even stay in the country. You've got no one to listen to you, no one to support you. You've experienced all this domestic abuse. So that might be another element perhaps to go down. How much does immigration and barriers of language affect suicide with domestic abuse?
Yeah, absolutely. I think that's a really good point. Well, all your points were, and no easy answers, but it just highlights the fact that there's a lot more research needs to be done in so many different ways. I said that I was hoping to do a PhD in this area. I think there's at least 150, 200 PhDs waiting to be written, and we just need to get them funded and done.
Yeah, and thank you for your work.
Yeah, no worries.
It's needed. Thank you very much.
Definitely. Thanks. I think Charlotte's next.
Yeah, hello. So I'm from the Learning Disability and Autism team in Surrey, and I have a safeguarding focus. I suppose it was more just to add to what people were saying in relation to a lot of the dual allegations and the complexity around those. And obviously that's where that professional curiosity element comes in, and I suppose that's kind of the point of today, really, isn't it? To kind of obviously try and investigate a little bit more. Someone said this and then someone said that's happened, and trying to work that out. But that obviously takes a long time, and going back to what I've forgotten his name now, the gentleman at the beginning, Nick, thank you, what he was saying about sort of all those systems and maybe the time that we have available because of those systems, like to kind of really drill into, from a social care perspective anyway, I think. I know we have lots of other external resources we can tap into as well, but the time that might take to really do some of that work with survivors and with possible perpetrators and people that are both perpetrator and survivor, it takes time. And we also don't, as we've discussed as well, I think in the chat, that there's sort of a real want for training in around domestic abuse within, once we've qualified. So I'm a social worker. I did some training when I qualified as part of my university course. That was 5 years ago now. And there's not a lot available on a regular basis. I think someone did mention in the chat about something that is available, so I shall have a look at that. So it's kind of just to add to that sort of discourse, really. Thank you.
Thanks.
Thank you.
Thanks. It's really helpful. Jolene, do you want to go next?
Yeah, sorry, I keep putting my hand up. It's just really interesting. I think from a SAR perspective and the joint reviews, the DADR reviews that we're currently holding, there is a lot around those comorbidities. So I think a couple of people have mentioned in the chat about perhaps the removal of children, substance misuse as well, but also the child to parent, abuse. That's sometimes understanding that a little bit more as well. So if you've got people living in the same household, so I know from a SAR perspective, it could be elderly parents and their sort of older child parent has moved in together, and it's that kind of understanding those other complex domestic abuse kind of situations, and just that definition of a household. I know we often get that in some of our reviews around, they may be in a relationship, they may not be, but then there's been that perpetration of DA in that household and understanding the links there as well. So, but thanks, Tim, it's been really interesting.
Yeah, no worries.
Thanks. Sian?
Hi there, so I'm the CDOT manager and all-age specialist safeguarding nurse in Hampshire and Isle of Wight. I just wanted to ask Tim whether or not, do we have any data for those young people who die from suicide who perhaps are living in a home where domestic abuse is a factor?
Yes, we do. I can answer that one. And I've put it in the chat because I just saw it in your earlier. So yes, and ironically, well, I don't know whether it's ironic or not, but 30-odd%, 32, I think, I want to say again, of all teenage suicides, so that's under 18s, 32% of under 18 suicides have been amongst children growing up in a household where DA is present. So that's from the National Child Mortality Database, which obviously, as you will know, kind of reviews all of the child death overview reports. So it's a couple of years old now, but 2020, I think it was. But that was the figure they came up with, that 30% or just over 30% of all teenage suicides are amongst households impacted by DA.
Thanks, Tim. Nicola, do you have the questions from the chat? Because I know we just got 3 minutes.
No, of course, I'll summarise them down there. Tim, again, there's an incredible amount of thank you, great presentation, and really interesting to see lots of thought-provoking things as well. In terms of some of the questions, it's more about numbers and data. So if I just lay them out and you can say which ones you do or don't have, maybe might be the easier way. The first one is about women who have completed suicide and their children were removed, but they have no access from their partner. So it's quite a specific one. Is that something you've...
So I wouldn't say we've got, I would not say we've got complete data on that, but what I would say is that is a scenario that does come up in our real-time suicide surveillance. I think, as with every methodology, we don't capture everything perfectly, but absolutely, that's definitely a scenario that does come up, and you can, obviously, it just goes, it's common sense, isn't it? You can understand why that would be a major risk factor for suicide.
Yeah, thank you. The second one is about stalking victims, and does your data include?
Yes, yeah, it absolutely includes stalking victims. Yes.
Yeah. Perpetrators being the victims in their early years. Is that within your?
So we can see that if the police record, if it's known to the police, yes. What we haven't got, and I should have said in terms of the going back to the stalking data, yes, we do have it. It's not particularly useful because we look at all of the different types of abuse that's happening, and we then have a catch-all which just says this person suffered multiple forms of abuse, and by far the biggest response to that question is multiple. So we need, again, continuous improvement, isn't it? We need to get a better at understanding, at splitting those out. So yes, it might be multiple, but actually which factors was it multiple of? The same for the next question, which is the perpetrator in terms of experiencing abuse as a child or earlier life. We can have that. We have that data where the police record it. What we've not done is had the time or space or internal resource to really investigate it in detail. But if I do get the funding to do the 3-year PhD, that's one of the questions that I would absolutely look at.
Brilliant, thank you. There's lots of others in there as well, in terms of people wanting to know more about your victims and perpetrators. So the cohort you said are both. Does that, is your published work, is that available somewhere to kind of unpick that with a bit more?
No. No, because the big report from the Churchill Fellowship isn't published, but even when it does, it's not going to go into that level of detail. It, as I say, it needs a PhD on its own. It needs someone like, I saw Jane Monckton Smith's name in the chat earlier. She's a brilliant academic down in the West Country. She's done a lot of great work on domestic homicides, but she's also done a couple of studies on suicides as well. But it needs someone like that, and there are a couple of other really good academics dotted around to really focus on each one of these mini cohorts, as I say, and really get the level of research done. And to be quite honest, that's basically what I spent my time since 2018, or we spent our time as a team between 2018 and 2022. Arguing for that nationally, we just need to get this up the profile, up the agenda. We need politicians looking at it. We need academics, charities. It didn't really kick off, so that's why I kind of tried to get my research fellowships, and thought, well, if no one else is going to do it, I'll have a try. But we're definitely at the very early stages of just trying to work out what the questions are that we need to be asking, rather than having the solutions yet.
Yeah, fantastic. Thank you, Tim. That's all of the questions in the chat, really. There's lots of other points in there and things, but they seem to have kind of resolved themselves. And just on my point, just to say thank you, and good luck with the PhD. Not an easy task. And I think you've kind of highlighted there, one of the things is we all try to do research in various different areas, and you're always going to find, as soon as you open one box, there's 1,000 other strands you should be you kind of go, oh, that looks good, that looks good, that looks good. But your research questions have to be so kind of focused, otherwise you would have a million word PhD rather than 90,000 of what's expected. So yeah.
Thank you.
Thank you.
Yeah, appreciate that.
Yeah, thanks, Tim. And obviously we need to book you in now to come back when you
give me 5 years. Yeah, 4.5 maybe.
Hopefully you'll come back before then. But we're really grateful to you for sharing your expertise with us, and there's loads of positive comments, but also loads of questions. That just shows how important it is, the work you're doing.
Thank you.
So thank you so much. I think we're going to move on to myself and Jolene and Karen. Is that? I think we're all here. Yeah, Jolene's going to share her screen.
Yeah.
Shall we, do you just want to introduce yourselves? Because I've introduced myself already, haven't I? Just to, before we start speaking, does that work?
Yeah. So hopefully you can see on the screen, I'm sharing now.
Yeah.
So I'm Jolene Llewellyn. I am the SAR coordinator, so that's the Safeguarding Adult Review coordinator for Surrey Safeguarding Adults Board. Georgia isn't able to attend today, so I'm going to be doing a little bit of a dual role, and I'm going to talk about the domestic abuse related death reviews as well. And my colleague Karen is here, so I don't know if Karen wants to introduce himself as well.
Thanks, Jolene. Morning, everybody. I'm Karen Sandhu. I'm the Partnership Officer for the Surrey Safeguarding Adults Board. So I work closely with Jolene on some of the work that we're going to be discussing today.
Thank you. So the three of us are going to present some of the themes and learning around all age suicide. So as part of this work around professional curiosity, we want to ensure that we're looking at that whole life course. So we thought we would share some of our data from Surrey with everybody. Are you all right for the next slide? And I just wanted to start by just highlighting again, I know that both Nick and Tim have mentioned that as well, but that complexity around suicide, and so because suicide is so complex in itself, that suicide prevention is also really complex. And just a reminder that when we're talking through this information and we're talking about data, just to remember that we are talking about real people. But when we're looking at the data, it is really important because we can use that to understand some of these issues, and it can explain to us where we might want to put some of our resources around prevention, and also to understand if the risk is changing as well. Next slide, please. So as I said before, so I work in the Child Death Review Partnership in Surrey, and for those people who don't know, so we get notified of the deaths of all children who were resident in Surrey, and we've done a lot of work which is available as published work on the SSCP website. I can put the link in the chat, and we've put together a thematic review of all the children who died by probable suicide, and we started with a 6-year review, and then we did an 18-month update, and now we've got a 9-year review. So between the 1st of April 2014 and the 31st of March 23, there were 488 neonatal and child deaths who were notified to our partnership. And of those, 18 were identified as due to probable suicide. So what we wanted to do is to try and understand some of the sort of reasons and try and understand the children's lives. So we looked at more detail around the themes, and what we did, as Tim said before, was we looked at the National Child Mortality Database report as well, and we compared some of the key issues that they identified with those children who died in Surrey and tried to map them. I should say that there are, thankfully, our numbers are low in Surrey, so we can't show statistical significant difference between our numbers and the national data, but they do highlight a trend and start to highlight some of the issues for children. Next slide, please. So I'm hoping everyone can see this, but on the left, so these are the issues on the left that were identified by the NCMD, and those in the second column along are the percentages of children who are affected by those issues. And then in the next column is the children in Surrey and the percentages of children. So we can see even with the top row that household functioning there's a higher percentage of children in Surrey affected by household functioning, and I think that highlights some of the issues that Tim's talked around domestic abuse there. Also, children engaging in risk-taking behaviour, and also what we also noticed were children or their families reporting issues at school as well. So that's something that came up. We also know in Surrey that we're seeing more children who's had been reported as having neurodevelopmental conditions than we would expect to see in the population. So we're seeing an over-representation of those children. So these issues start to highlight to us where we might like to put our resources in terms of prevention work. Is it all right to have the next slide, Jolene?
Yeah, I think so.
So what we did is with our work was we came up with a number of opportunities not to be missed, and those have been incorporated into the Surrey suicide strategy. And just to highlight one of the main areas where we think it's really important to focus our work is around ensuring that schools engage with the Surrey Healthy Schools programme, because we know that the evidence shows that where we support a whole system approach to improving children's mental health, that's where we can show the biggest impact. And also the UNICEF report on children's mental health in teenage years highlights the importance of that early prevention and support for families and parents and parenting. So those big issues are at the heart of the recommendations we make in our thematic review. And on the SSCP website is a timeline of some of the work that's taken place as a result of the initial thematic review. So the links there if people want to have a look at some of the work that's taken place across the whole system. I think that might be me.
I think it is. Do you want me to carry on and we'll do questions at the end?
Yeah, that's what I thought, if that works.
Yes. Yeah, that's fine. Okay. So I'm going to go through this. I won't go through every slide in lots of detail because hopefully you all know. I know there's quite a few people on here that would already know about me or about our service. So I'm from the Surrey Safeguarding Adults Board. I am the SAR coordinator. That's the Safeguarding Adult Review coordinator. And just to give you a little bit of an overview, a Safeguarding Adult Review, it is under the Care Act 2014, so there's a link there if anyone wants to have a look at it. And it's really around if there is a reasonable cause for concern, if an adult or adults have been has died as a result of abuse or neglect, or have reasonable belief that they have experienced abuse or neglect. And we do quite a lot of these reviews, and in Surrey at the moment we are slightly higher than other areas. And it's just really important to understand what that looks like. We do joint reviews, which I'll talk a bit more about in detail after. But just to give you a little bit of an idea, this is what we've got going on at the moment. So these are our most recent numbers. So at the moment we've got 41 reviews that are ongoing, and that's at different stages. The review process can be quite lengthy because sometimes we do have parallel reviews going on. Sometimes we have other situations. There may be a coronial process, there may be a police investigation or other internal safeguarding reviews that are ongoing, so that may cause the delay. But these are the reviews that we've got on. So 26 of them are SARs and 14 are those joint reviews that we mentioned. So that's a SAR and a domestic homicide review that they used to be, and then the domestic abuse related death reviews that they are now. And we've also got one at the moment that is a joint review with the leader process. So that's understanding some of those complex issues we've mentioned before. Just to break it down, at the moment we've got 25 that were female victims or people that have passed away, and 16 were male. So some of the themes, and I've just drawn out some of the key ones, but out of the 41 cases, 31 had evidence of mental health issues, whether they were accessing services or they were reported to have mental health issues or a comorbidity. It's really important to understand that quite often it isn't just a standalone thing. They have many things that are going on. 20 of those died by suicide or suspected suicide. 13 experienced domestic abuse. 6 had that experience of neglect. 5 featured substance misuse, so that could be one of those comorbidities. 3 was cuckooing. That's quite a newer theme that we're seeing, and that fits into that exploitation. That could be, sometimes it's called home evasion, where people move into their property and take over their property. And we have 2 that have died by murder. And that fits in with that domestic homicide or DADR world that I talked about. But we've got quite a few themes that overlap that all fit together as well. So it's important to understand that. So whenever we have a review, we always end up with a recommendation that translates into action plans. So here are just a couple of the examples that have come out of our reviews. So the SSAB, so that's the Safeguarding Adults Board, to receive assurance from partner agencies that their suicide risk and prevention strategies include a commitment to develop a suicide risk and safety plans with adults and their families. And I think it's really important that we start to talk about where it's appropriate, but engaging families in those plans, engaging other positive factors to help support people that may be at risk of suicide or self-harm. Make sure that there's a lead professional involved. Make sure that we look at all suicide attempts and include that in any safety planning. I think that's really important, and that goes back to some of the other things that have been said already around that, just having those conversations, talking to people, and understanding, their lived experience. And that's the whole point with the Safeguarding Adult Review. It's about understanding what happened with that person, and being able to factor that in. Another one, and this was one for Surrey Police, and they had a recommendation to flag or alert assist on their system, to be able to show if there's anyone that's involved in suicide behaviour. So that's that joined up approach. It's a bit of a cliche, but it is everybody's business. So understanding what each agency can do to support that, and to link in with each other and work together. The other one is about exploring options for developing a flexible and person-centred approach. That's making safeguarding personal, really. It's understanding what is available, what other services are out there, and trying to understand how to engage with people. It may be that coming to an office or coming to a community centre isn't the best place. It may be that you need to go and see them in a safe place that they feel comfortable. It may be the use of online or other different ways of engaging people, but it's understanding what is best place for those people. And then the other final one I just wanted to raise attention really is that we do have an opportunity to escalate to a national panel. This is to start to think about how we can possibly inform some changes within guidance, to be able to co-produce some guidance, to start to look at how we can make changes as well. We have a lot of national groups that we sit on that we can also link in with them to look at good practice in other areas and understand what's going on, so that we can start to look at different ways of working. So there's some of the recommendations that may come out of a review. Sometimes they cross over, sometimes they're for individual agencies, but they're mostly for multi-agencies because it's about that learning. One of the key things about Safeguarding Adults Review is it isn't about apportioning blame. It's about how we can learn, how we can do things differently. So it's looking back, being able to look at how we can develop things to move forward. So we learn from that. And I think that goes right back to what Nick said this morning about that, being able to do it differently and hopefully learn from that. So some of the learning points that do come out of this. So inadequate suicide risk assessments and management. So we have found that sometimes, that suicide risk isn't sort of assessed appropriately. There isn't, safety plans in place. So, sometimes we don't act quickly enough. It's about having those really difficult conversations sometimes, and being prepared to kind of work with people around putting that safety plan in place. We're having more and more where it's that impact of adverse childhood experiences. So people that have been affected by trauma in early life and continue to have some trauma as an adult. It could impact on their mental health. Often we're having more and more that are younger and struggling with that transition from childhood to adult services. If we've got a couple where it's children that have been formally looked after, and it's that understanding around what services are in place for them as they transition into adulthood. So it's understanding that and having like a trauma-informed lens when you're working with people. Always, sadly, this is something that comes up in most of our reviews, is that fragmented information gathering and sharing. Sometimes there isn't that collective response around historical mental health information. There isn't always that joined up approach to see what other agencies are involved or working with that person. So sometimes it's as simple as picking up the phone and understanding what agencies were involved, who was offering support, and sometimes knowing that just because there is another agency involved, it doesn't necessarily mean that they're actually offering that support at that time. So that collaborative approach and understanding what the person wants as well. Another one, family involvement in care decisions. Again, this comes up in one of our most recent reviews that we've published under the name of Louise. That talked a lot around the family weren't involved in the assessment and the care planning process. It basically limited the support that could be provided. So actually, the family had a lot of information that they could have shared to be able to best support that person. So those are some of the learning points. And I suppose I wanted to kind of draw your attention to the reviews. It's not always about when things have gone wrong. Sometimes it is about that good practice, and we like to be able to identify good practice examples. We want agencies and professionals to share when they feel like they've done something really well. Getting that feedback, I think it's really important. So Some of the challenges in reviews, often it is difficult to identify good practice, but here are some of the ones that came out of the reviews. So there was a persistent effort by professionals to engage and support the individual, even if they had disengaged. So this was a person that had disengaged from all services, they'd kind of stopped attending appointments, and actually people went above and beyond and said, let's work out how we can do this, let's link in with you in a different way, let's meet you in the community, let's meet you here, you tell us what you want and we'll try and work around that. So that was a really positive for that person. Flexible approaches to care, so it's understanding what it is they need and want and how you can achieve that. That was another one. And then the other one was around that significant efforts by a voluntary sector accommodation provider to prevent homelessness. And that was actually going above and beyond to support that person, because they knew that if they become homeless, that would massively increase their risk. So it's about identifying that good practice and sharing it. And we often ask agencies to share that across the board so that other agencies can understand what that looks like. So I think that's really important, and we should be promoting good practice more. Next slide really is just around, this is where you'll find some of our published adult reviews. It's updated regularly, and what we tend to do is we have the report, we have an exec summary, and we have learning reviews, and we try to incorporate some of those key themes when we deliver some of our webinars and some of our other areas about raising awareness and updating our resource section. So I'm going to hand over now to Karen, who's going to talk to you a little bit more about his role. So Karen, just let me know when you want me to move over to slides.
Thank you, Jolene. Morning, everybody. So, as Jolene mentioned, I'm Karen Sandu. I'm the Partnership Officer for the board. And what I'll be doing today is just kind of talking about my role and some of the work that we've been doing to support some of the learning. So, Jolene, if we could have the next slide. As part of my role, I support the development and delivery of the key board priorities. So a key element of this role helps to build positive relationships with health, voluntary, community and faith organisations. So in the past 9 months, I've been able to support the development of the board's communication strategy. And I've been leading on this with the implementation and help of partners from the Safeguarding Adults Board. My role includes varied multi-agency working, so from supporting board subgroups and forums to help them become more focused and effective, and that helps us to align some of the key objectives in our strategy. So we can have the next slide, please, Jolene. So some of the work that we've been doing is supporting some work around empowerment network sessions, which have been delivered by the coalition. So in May, I attended the network sessions hosted by the Surrey Coalition of Disabled People. And the DENS is a group of people and their carers that are passionate about influencing and improving services within their area. And the DENS work closely with the NHS, the council and the police to kind of provide feedback and insights on some of the services that they offer. And this helps the DENS improve the quality of care and support that they provide within their community. And they're really committed to addressing some of the local and national issues around safeguarding adults with care and support needs. And not only that, they've been able to look at some issues around transportation and benefits that kind of have a massive impact on the DENS as a whole. So if we could have the next slide, please, Jolene. So some of the key activities that I've been working on, I've been linking in with the Minority Ethnic Forum within Surrey. So as part of our communications work plan, we've been able to develop a model to gain the voice of the adults with care and support needs. And this links in with the Minority Ethnic Forum to help advocate and approach to some of the work that we've been doing. So I met with the Wellbeing project manager earlier this month as well to discuss opportunities and how we can link in with some of their forums and subgroups to make our information more accessible. So a lot of the information that we have on our website may not be available to some of the communities that they work with. So we've been looking at ways in which we can make that more accessible within the community. Another way which we've been able to kind of link in with agencies across Surrey is the Surrey Community Action Group. So the board has been able to kind of look at ways in extending relationships across the sector and we've been able to kind of build networks with Surrey charities and help raise the awareness of adults across Surrey. Again, we attended the annual Safeguarding Partners Breakfast, which was held at the Diocese of Guildford earlier this year. The breakfast was basically an opportunity for agencies to come together to talk about the importance of partnership working and how we can work together to fulfil our commitment to safeguarding as a whole. And just as another element of what Jolene had discussed on some of our reviews and how we can work on that so what factor of the recommendations and actions that come out of the published reviews. We're working closely with colleagues who are from the Changing Futures programme, and we've discussed ways to kind of look at the lived experience of people who may have experienced the safeguarding process within Surrey. So I've been working with the project managers from the Changing Futures programme, and we're delivering a webinar in December around how we can showcase the evidence-based model of people who may have experienced the safeguarding process, and especially those with care and support needs. So, Jolene, if we move on to the next slide, I'll talk about some of the resources that we've got. So, there are just a few links to our engagement channels, including our Twitter feed, where you can find latest updates around safeguarding awareness campaigns. And these basically help the board promote key issues throughout the year. We have a rollout of webinar sessions, which I just mentioned around one of them, which is the Changing Futures one. So if you have a look on our website, you'll find the link to booking on these sessions. They are free, and we do encourage partners to share this as widely as possible. So you're more than welcome to share that within your agency. And it really is just a way of disseminating that learning. So especially from the reviews, as Jolene mentioned, we are looking to identify some of the key themes and safeguarding priorities. So if you have any topic ideas or know any webinar speakers that may be interested in delivering a session, please get in touch with either myself or the board. I would love to hear your thoughts on what we could do to kind of raise that awareness, and if there are any key issues that you feel the board should be deeming as a key priority, please let us know, and we'd be more than happy to look at that. So I'm going to hand back to Jolene, I think, who's just going to give a bit more insight.
Thanks, Karen. Yeah, thank you. So I'm going to now just quickly talk a little bit about the domestic abuse related death reviews. I know that we've already covered some of that today, and this is normally Georgia that would do this. And she's the DADR coordinator. I know she's going to be going off on maternity leave shortly, so she has a replacement at the moment who's called Fran. And I think it's Ryusha. I'm not sure. I probably said that completely wrong, but Fran will be starting to take over from Georgia. And the reason why I'm going to talk about this now today is that we work really closely together around the domestic abuse homicide reviews, and they link in with those joint safeguarding adult reviews. But there has been a Home Office consultation. So they launched a domestic homicide legislation on reviews conducted after fatal domestic abuse cases. In February 24, they announced that they changed the name from the DHR and they've moved it over to the domestic abuse related death review. So it's a DARDA, if you often hear that word. And it's basically to be able to extend that scope and to reflect what is going on. And that's really leads into what we've talked about already. In May 24, the Home Office launched another consultation to look at reviews, to look at and review the updated version of the statutory guidance. That ended on the 1st of July, and we're just waiting for that information to come through. But here is a link to where you can find some more information on that one. And it's really around understanding what that looks like, what they would include in the scope of that review. So if you want to have a look at that, there's the link to that one. So similar to the Safeguarding Adult review, it is a domestic abuse related death review is when you look at a person age 16 or over who has or appears to have resulted from violence, abuse or neglect. And it's under the two categories. They may have a person to whom she or he was related to, or with whom he or she had been in an intimate relationship with, or a member of the same household. And it's about lessons to be learnt from the death. So again, it's not about pushing blame, it's about understanding what that looks like. Where a victim has taken their own life, so by suicide, and the circumstances give a rise to concern, so it may emerge that there was coercive controlling behaviour in that relationship, a review should be undertaken. And then if a suspect is not charged with any offence or they are tried and acquitted, reviews are not about who was culpable. So it's again about that incorporating learning. When we have the joint reviews, we look at both the safeguarding element and we look at the domestic abuse element as well as a joint enterprise, and often the same group of professionals sit around both of those meetings. So it's about joining up the meeting so that we're looking at all aspects together. So the purpose of a DADA again is to look at those lessons learnt, is to look at how those lessons both within and between agencies have worked, what timescales they will be acted within, and the expected change or the outcome that we're hoping to look at. We want to look at how those changes may inform national or local policies and procedures. We want to prevent domestic abuse, violence and homicide, and to look at the response services. We talk here about children by developing coordinated multi-agency approach. We want to be able to basically respond and reach those people in a more timely manner. We want to understand the nature of domestic violence and abuse and highlight any good practice as always. And that links into some of that work that we've talked about already, but it's really understanding what those key themes are. The next slide is quite busy, so you might not be able to see it on the screen, but this is just to give you a bit of a highlight of the different stages. So within a domestic abuse related death review, there are 9 stages. So it starts off with when the notification comes in. There is a rapid panel meeting where we discuss what that notification is. We talk about whether or not it meets the criteria for a safeguarding adult review as well. And it starts to look at what some of the areas you want to explore for that one. With a domestic homicide review, it's slightly different to the SAR, is that you do have to notify the Home Office, and that is led by the Community Safety Partnership. So each Community Safety Partnership holds the responsibility, and they will lead on it. And if there is a safeguarding adult review, we will join up with that process. And then it goes through the several stages. I'm not going to go through all of those, but it goes right through to when we start. So stage 7 is where you have to submit to the quality assurance panel at the Home Office. So that's sent through. They sometimes give us feedback, and there is a little bit of a delay as well. So often we have to make sure that we start to incorporate any learning, and then we feed back to the Home Office when they come back to us, and then we publish that one. And that's published on both the Community Safety Partnership and within the Safeguarding Adult Board if it's a joint review, and I'll send you some links, or you'll have the links to where you can find those published reviews. Again, if there's any questions in this area, please make sure that you direct them to Georgia, because she'll be the best placed person to answer them. But here's just some of the statistics that we've talked about. So this is from August this year. So on the pie chart, it tells you the different areas that they are. So at the moment, there's 16 ongoing reviews, which 8 of those are standalone domestic abuse related death reviews, and 8 are joint DADA/SAR reviews. The 15 of the victims were female and 1 male victim. 12 of the victims died by suicide. So when we think about 16 in total, 12 of those were victims of suicide. There was evidence of mental health issues in all of the cases. Substance misuse featured in 11 out of the 16 reviews, and children, so that's by definition of those between 0 and 18 years involved in those cases, that was 10 out of the 16 reviews. And in the breakdown on there, it just tells you which different community safety partnerships have got reviews ongoing at the moment. Okay. So just to let you know, there are some training opportunities. So there has been an increase in the DADAs involving suicide in Surrey. So there was some training commissioned through AFTER. So that one is the Advocacy After Fatal Domestic Abuse, to deliver suicide after domestic abuse research, risks and reviews training. That's CPD accredited. So within that, they wanted to look at the prevalence of suicide and domestic abuse, recognise those links between domestic abuse and suicide. They wanted to talk about the value of experience of a family member bereaved by suicide, and there was a really powerful speaker that came along and talked about her experience of losing her child to suicide after domestic abuse. They wanted to acknowledge the challenges faced by families, advocates and community safety partnerships, and the chairs when reviewing suicide or unexplained deaths following domestic abuse. It is really challenging. We've talked about that a lot today, around those comorbidities, around other factors such as children being removed, mental health, substance misuses that all fit into that, and understanding how the domestic abuse has impacted on that person. Obviously, one of the biggest roles is around the inquest and the coroner in domestic abuse related suicides, and we talked a bit about that within that training. And moving forward, after we've also been recently commissioned to deliver some training on self-care in DHRs or DADRs, and that's going to be delivered to the regular panel members that normally sit within the DADRs, and it will be taking place in November, that one. So some of the learning objectives from that is understanding the impact of vicarious trauma. And I think we've talked throughout the session today around that, but it's really important to understand that. Understand the importance of self-care and identify sources of support during and after the DADR process, because a lot of professionals sit on these panels, sit on both the SAR and the DADR panels, on top of their already quite emotive day jobs. It can be quite challenging. Some of the content that we get to see and review is really quite emotive, and it goes right back to that there is a person at the centre of it. So I think it's really important that we understand self-care and that vicarious trauma. And actually moving forward, we're also trying to look at some more learning and training opportunities in the future. So one of the examples of that is giving children a voice in DHRs. Also, myself and Georgia, we sit on a working group, and Karen sits on that as well from the co-production area, around starting to look at some of the key themes. We're currently working with the community safety partnerships on learning from reviews, and at the moment that's looking at suicide as a key priority. I'm going to do some work on that, and hopefully there will be some sessions that come out of that shortly. So if you've got any questions on DADRs, here is Georgia's and Fran's contact details, and just to be mindful that Georgia is going off on maternity leave, so it will be Fran picking it up from the 24th of October, and that is it, I think. So we're just going to come back to you, Nicola. I think it's any questions now.
Yeah, thank you. Thanks for that. There's a few questions in the chat as well, so it was really helpful to have that overview though. I don't want to take all the questions, so I'm hoping there'll be some for you too. Somebody did mention though, and it's something that we have identified in Surrey, about that support for staff members on the front line that have to attend coroner's court, and it's a really good point about ensuring that we've got effective mechanisms in place. And I know there is some training available, but we're looking to see whether we could have a consistent approach across Surrey for those staff, because we know how hard it is for staff attending and making sure that all the support mechanisms are in place. So if anyone's interested in that, if they wanted to get in touch, because it'd be really helpful to hear what people think of the gaps around that. That would be great. I'll put my emails there, sorry. Please do email me.
Yeah, I think I've stopped sharing now, but if there
I can still
yeah, there you go, still there, then that's fine. Yeah, and I think just to add to that, Nicola, sorry, I know that we've been doing quite a lot of work with the coroner as well to understand that kind of link between the SARS and the coronial process and how we can support staff. But absolutely, if there's anything else that we can do on that one, please let us know.
I don't know if anyone has got any questions, if anyone wants to put their hand up. The other issue that was in the chat was around that support for people who haven't got who might not have a diagnosed learning disability, who might struggle with some of the resources, and it would be really, it's really good, isn't it, to keep that in mind when we're looking at the resources that we're producing.
Absolutely. I was about to say, I know that we've been doing some work, Karen and I, around how we can make resources slightly more easy read, a little bit more visually kind of engaging as well, because sometimes you get lots of words in a document, and sometimes you just need it to be a little bit more simplified. So we are doing a bit more work on that around accessibility as well.
I know as well, somebody asked earlier about safety plans. I put in the link for safety planning for children and young people, but it'd be helpful if anyone has got a link around safety plans and adults and suicide risk. That would be helpful to have that in the chat. I don't know if there are any other questions.
There's no other questions specifically, Nicola. The only thing was Helen Channer has said about the fact that phones and devices of young people are not routinely reviewed where there's a suspicion that a child has died by suicide. And I know that in Surrey, actually, the police do look quite thoroughly at all of the phones and devices. So perhaps that's regional variation or national variation that can be raised wider as well. Something to take forward to the National Child Mortality Database, definitely. Oh, and Shard's put phones are reviewed in Hampshire too. So yeah, it's obviously different areas have different processes. But apart from that, just people saying thank you for the presentations. Very sad, but very helpful and informative. So thank you.
Thanks, Nicola. And thanks, Jolene and Karen, as well, for coming today. Really grateful to have your expertise here and input. It's really useful. I just wanted to say that after this morning event, we are running these roundtable events. So we have already run some for Sudi, and they're really they've worked really well. So the format is that we come together in a smaller group, and people keep their cameras on, and we look at some specific issues. So we could look at some specific issues around suicide, and as everybody has an opportunity to reflect, and those are recorded and then shared on the SSCP website, and other people can access them and use them for staff training as well as their own learning to start discussions. So it'd be great if anyone is interested in helping support from their expertise in running those sessions. But also we'll get the dates of the ones that we have planned on the SSCP website by the end of the week. Nicola, did you have anything you wanted to add about that?
I was just going to say that if anyone wanted to kind of see it in action, we have already uploaded one of the Sudi roundtable events, which was the first one we run. We do have another one to pop on very soon, so there'll be two. And I've also popped the link in the chat. So although the sessions aren't there yet, we were going to wait till after today and then put them up so that people can find them. But it's just self-book on, and we'd love to see you there. So thank you.
Thanks. So I think I'm going to hand over to Rachel. Hoping you're there.
Hi, yes, I'm here.
You're here. Oh, that's good. I was starting to panic a bit.
Sorry, give you a minute of heart attack before I actually produce myself on screen. So yeah, I'll
You want to introduce yourself, Rachel? Sorry, and your session.
Absolutely. Yeah, of course. I think it's still morning, isn't it? Good morning, everybody. My name is Rachel Williams. I am the Surrey Suicide Prevention Force Advisor within Surrey. And one of my roles is that I, sorry, I'm just working out whether I'm sharing or not.
You are, but we're not on, you know, like you're sharing yours, but it's not on slideshow.
Sure. Let me just get that going. That's better, isn't it?
Yeah, that's it.
Fabulous. Yes, so sorry, my name is Rachel Williams. I'm the Suicide Prevention Force Advisor in Surrey Police. So I run the real-time surveillance system, which Tim, in his discussion, obviously his presentation explained that that's where he gets his data from. So this presentation really is around going back to basics really, and saying where all this data actually comes from and how it's used. Certainly within Surrey, it is a national. There is a national system. There is a national real-time surveillance system as well, which I'll explain in a bit. And so all forces do have the ability to provide this data, but we all do it in different ways, as we always do. So as I know we've looked at before, obviously this is suicide is a tragic and distressing subject matter. So just to, a bit of a health warning, please look after yourselves, step away if you need to. I am going to look at a few risk factors, and obviously I'm talking about suicide throughout this. So yeah, just a case of look after yourselves, please, and do what you need to do. So as has already been mentioned, suicide prevention strategy for England was published in September last year, 2023, which set out the ambitions and visions for suicide prevention for England. I've pulled a few of these together just to highlight them. Firstly, obviously, one of the ambitions and visions was that suicide is everyone's business. Everyone should feel that they have confidence and skills to play their part in preventing suicide, not just within the mental health or suicide prevention areas, but take it, for everyone to feel that they can take action to prevent suicide within and outside of health settings. The concept that mental health is as important as physical health, trying to reduce that stigma around suicide and mental health so that people feel able to seek the help that they need, especially through routes that work best for them, which may not necessarily be the routes that we think or we naturally turn to. And it includes raising awareness that no suicide is inevitable. Early intervention is vital. In addition to providing support to those experiencing crisis and or suicidal thoughts or feelings, action needs to be taken to stop people reaching this point. So I do discuss it a little bit later in this presentation, what we can do and how we can do that, having those early conversations with people, which falls into the professional curiosity, but not just professional curiosity, just in general throughout life, checking in with friends, colleagues, family, and just checking that they're okay in an attempt to get them help and support should they be feeling not so well at that point. And then timely and high quality evidence. So data and research, Tim's obviously explained a lot about his research in relation to suicide and domestic abuse. And obviously I'm here to speak about the real-time surveillance and what that provides. So it sounds like a great system, and I'll explain it a bit later, but basically in my world it's just a lovely spreadsheet that I'm very proud of, but it does what it needs to do. So one of the priority areas for action is in relation to that data and evidence, ensuring that it's timely and effective, and is continued to be developed. So, for example, having understood what Kent have done, that like Tim has explained in relation to domestic abuse. A couple of years ago, I did actually change my real-time surveillance to include the domestic abuse element, so that I can do a similar reporting to that which Tim has produced in relation to Surrey deaths, and hopefully then we can target work in relation to that area, and also other areas where they come up as being shown as priority areas or high risk areas. And for example, the real-time surveillance system also assisted providing timely monitoring of suicide rates during the COVID-19 pandemic, when we weren't able to get as much data, but that data was available. So what is the real-time surveillance system and what does it do? How do we get that information into it? So as I say, from my point of view, it's a very pretty spreadsheet that I'm proud of. But what it does is it records suspected suicides. And I've been recording those since the 1st of January 2020. I've been enrolled since July 2020, but was able to backdate the data. So we now have 4 full years of data, which allows us to provide comparisons year on year. The advantage of the real-time surveillance system is that it's pre-inquest. So the data that's taken from the police systems are within days of the death, rather than waiting for ONS data, which captures the data once the death has been registered, which is post-inquest and can be 2, 3, sometimes 4 years after the actual death. So by obtaining this data at an early stage, we can be a bit more reactive to what it's showing us. But it's always very important when we are looking at data to make sure we are looking at like for like, and not looking at, when we look at the ONS figures, they are going to look very different to the real-time surveillance figures, because they are captured at very different times. So it's just always important that sometimes when you're looking at data, you go, well, none of that's marrying up. Are we looking at the same data? Now, because police have to attend all deaths outside of a hospital setting, as we act as, if you like, agents for the coroner in relation to that, it's estimated that we can capture up to 95% of the suspected suicides in Surrey. As a result of that, obviously that shortfall of 5% may not be captured because either, as I've indicated, it's where individuals have died in hospital where police haven't been involved because they have had a prior admission, either by ambulance or a self-admission. But even now, some of those are being captured with the coroner requesting police to attend where there is perhaps some suspicion of a suicide. And the real-time surveillance records all ages, so it does give us a very good picture. I should also mention that because these are pre-inquest figures, again, what sometimes skews the ONS figures in comparison are that there are some of the deaths that I've recorded as suspected suicide might not be later deemed to be a suicide at inquest. But they remain on the real-time surveillance system as being suspected. But also, therefore, there may well be deaths that are recorded as a suicide that haven't been captured on the real-time surveillance, because obviously the coroner will have access to a lot more information than is available when it is originally recorded on the real-time surveillance. So what sort of data does the real-time surveillance give us? So I produce an annual report from this data, which breaks it down and gives varying levels of information. So, for example, this first page is showing year-on-year comparisons for 3 years. So from that, we can see that there isn't a lot of pattern to it realistically, but it can help us when, for example, in September, 2 years, we actually got quite high numbers. So it can help us to look, therefore, and say, well, what went on in that September? What was going on? Maybe break those years down and find out what the comparisons are, and it just helps to then inform our suicide prevention going forward. We can see that from heat maps where these suicides, suspected suicides, are occurring. And I should say that the reason I'm calling them suspected suicides is because it is pre-inquest and it is for the coroner to deem them to be a suicide. So from the heat map, we can see what's happening. As you can see, they're very, very centralised on towns and areas, but it helps us to a picture tells 1,000 words, doesn't it? And helps us to have a look at where there may be areas that we need to look at and do more targeted suicide prevention. We can then break it down into boroughs, which again provides us with more information as to which areas. Again, obviously these are quite consistent with what is being shown on the heat map in the previous bit, but it just helps us to get that picture. Obviously it is broken down into male, females and others, and yeah, helps us to see that as you can see, the blue being male is you know, the majority of numbers within our data is that males are around about 75% or 70 to 75%, and then females or other are within the 20-25% mark each year. And then we can break it down into ages as well. So this is last year's data for 2023. Thankfully in the under 18s, you know, well, any of the deaths are not nice to have, but numbers are relatively low or very low in under 18s. However, the 18 to 24s is an area that's looked at by the children and young people groups. So albeit they're adults, they could be people at universities, and as we know, those up to the age of 25 their brains haven't fully developed, and therefore their powers of making the right decisions are not necessarily, they're not completely developed in that. So that age range is still quite a key age range to be looking at. One of the other factors that we've seen is right at the other end of the scale recently. Last year we saw an increase in numbers of the of individuals who were over 75, which is a concern as to what's happening, and in fact those numbers are continuing into 2024, and therefore this can be raised in groups to try and establish what work we can do in relation to those people to try and reduce those numbers and reduce the suicides. So the data also can provide characteristics of those suicides or risk factors. So this is the top 18 risk factors that were present in the suicides in 2023. This table is always quite useful producing it, although it should be noted that although these characteristics are present, it doesn't necessarily mean that that is the reason for the person choosing to take their life. These are just present. It's the risk factors and characteristics are subjective. There also can be a general catch-all headings. So, for example, within relationships, that could mean a breakdown in a marriage. That could be a 6-month relationship for a young person that's just broken up. It could be it could include the domestic abuse element, although I do also record the domestic abuse on a separate indicator as well. Just as it could be in relation to financial issues. Clearly that can cover lots of things like gambling debts, like out of work, not being able to work. So they do cover a lot. And I know when asked in relation to adverse childhood experiences, Again, that can cover a lot of things. Has the child suffered trauma in their childhood, which could include parents breaking up? It could include a bereavement there. It could include trouble at school, and all those key factors that come into it. So they are very broad headings, but it is a good indicator of what is present and what is going on, and therefore what we can do to try and assist with prevention. So how is this data used? So the real-time surveillance is shared with Public Health and the Suicide Prevention Board. It's also fed into the learning and postvention groups for both adult and children and young people. So from those groups, we're able to really look at those trends and look at groups that may be at higher risk, to ensure that learning and suicide response processes are in place, and to oversee any postvention support that may arise. Recently, Public Health have acquired the QES system to allow for some of this data to be triangulated. So the majority of the data is from all the information initially is from the police, which is put onto the QES system, and then that can be triangulated with SABP. So they're notified that a new case has been put on. They're asked whether they have records of that person, and they can therefore fill in additional information. As I'm sure you can appreciate, the police don't always have all the information, and as it is being collected at such an early stage, it's not often available at that point. And as I said earlier, there is a national real-time surveillance system, which is run by British Transport Police, who lead generally for the police in relation to suicide prevention. There's oversight by the National Police Chiefs Council, and we have a suicide prevention lead within the NPCC who also has a national meeting, so that all areas can come together, compare notes, look at what's going on, and try and share good practice and help each other in trying to fight against suicide. So we also have 3 years of attempted suicide data, but this is police only data, and therefore it's very limited data. Even for myself, I can't capture everything on the police systems, so I have a very select search criteria that I use. So I can only ever say that it's a snapshot of what's going on. And unlike suspected suicides, because we don't attend all attempt suicides, there is a lot of data from a lot of different other organisations. So as I say, it is just a snapshot of what is available, but it can give some really good indicators, which can really help to work towards suicide prevention. And the other area that comes out of the real-time surveillance is that postvention bereavement support. So as you can see there, bereavement support is suicide prevention. Research shows that those bereaved by suicide are themselves more likely to attempt or die by suicide themselves. We have all those questions of why didn't they talk to me, why didn't they seek help, and that in turn can make people become very, very focused on suicide, and that can then in turn affect their mental health. So it is known that it is considered to be good practice to enable those that are bereaved by suicide to have access to suicide specific bereavement support at the earliest opportunity. Therefore, as part of the real-time surveillance work, when there is a death, the next of kin are sent a support pack, which includes the Helpers at Hand document, which is an NHS publication, and details of other organisations that can help them that are local. They are also automatically referred to the Surrey Bereavement Service, which is currently the Surrey Support After Suicide, which is provided by Rethink. This is done, as I say, automatically. We don't wait for consent of the individuals, and the reason we do that is because national guidance from the NPCC is that we should be doing automatic referrals, in the fact that it is better that we maybe get a complaint from somebody who was referred, then not do anything, because by not doing anything, that person may well then suffer with their own mental health and attempt or die by suicide themselves. So that's the choice that we make in relation to the automatic referrals. The individuals have the option, obviously, as soon as they're contacted by the support after suicide, to opt out of this. And obviously, if they do that, then there's no further contact for them. But it's also important to think about not just those directly affected by suicide, but for those that are exposed to suicide, like witnesses, first responders, neighbours, colleagues, and care professionals, ensuring that those people also have help and support in order to help them to manage the impact. It's often even more difficult for those that are affected by it, that don't know the person, because they don't really understand why they're feeling the way they're feeling, and therefore that can really affect them. So Surrey Support After Suicide also offers help and support for those affected, and there are lots of other organisations that do as well. And there are postvention groups that are often formed in order to just assess the risks of these people, and therefore ensure that there are other support mechanisms put in place. Like, for example, when there is a death at a university, the other students, they might not know the person, but become aware of a suicide, and it's important working with the universities to help them to provide that health and support for all their students who may well be affected. So 10th of September, beginning of this month, was World Suicide Prevention Day. The theme of this year was change the narrative, start the conversation. And as we saw from the National Suicide Prevention Plan, suicide being everyone's business. So it's important to really try and break down the stigma of suicide in everyday life, whether it's through work or whether it's in general conversations with everyone. Not being scared to use the word suicide, being open about it, so allowing those that may well be feeling suicidal to know that they can talk about it and can be heard without judgment. Now, it can be really, really scary to have that conversation with somebody. You need to be prepared for it, because there's nothing worse than hearing that somebody is feeling like that if you're not in that professional capacity and have that training. And even if you have had that training, if it's somebody that you really care for, it's a really difficult conversation to have. So there are resources out there that can help you. So the Samaritans have a how to start a conversation with somebody who needs help on their websites. As Tim alluded to, there's the Zero Suicide Awareness training, which is a free 20-minute video training, which is really highly recommended. In fact, it's recently been updated, and I actually completed it again because I wanted to see what it's like, having had the revamped version, and it's a really good, really helpful. Sorry, I think I've changed slide back. Sorry. It's a really useful, helpful resource. So, you know, for everyday life, you should watch that. Everyone should do it. And something like the Stay Alive app, I know there's a lot of other apps as well, the Hub of Hope. Download them onto your phone, encourage others to do the same. If you're having the conversation with somebody maybe who is feeling suicidal, it's a good one to have. You can show them it. There's lots on there. There's a safety plan on there. There's a life box where you can store inspiring photos, images. So if you're not having a great day, you can look at that and think, yeah, this is what I should be focusing on. And to show it to somebody and get them to download it. There's loads of useful facts and tips, resources on there to get help and support, whether you're helping someone or whether you yourself need help and support. So that is literally just a whistle-stop tour of my presentation. If there are any questions, please let me know, but I think I'm pretty much on time. Yeah, so I'll leave that with you. Thank you.
Thanks, Rachel. That was really helpful, really useful session to hear all of that. Thank you very much. Really grateful for your expertise. I think Alison was going to come in.
I am, yes. I was just waiting, Nicola, just to see if there are any questions. I couldn't see any hands up. So yes, I think I've got the last few minutes, haven't I, just to say a few words. So those of you who don't know me, I'm Alison Cutler, and I'm the Partnership Development Manager for the SSCP. I'm really delighted to have been able to support this event this morning. I know there's an awful lot of people who've put an awful lot of work into this, but I'd just like to say thank you very much to all the speakers. I think we've been taken on quite a journey this morning, from the sort of psychological background to professional curiosity to more sort of real-time data that's just been presented to us, as well as all the themes from the learning, and then very interesting links across with domestic abuse. So I've learned an awful lot this morning, and I think it's been really helpful, and I hope I can see some of the comments in the chat as well. People seem to have found it very useful. I'm not going to keep you all on the call for very long. Just a couple of things really. Professional curiosity is one of the things that keeps coming up in all of our reviews, and this programme is really aimed at trying to spark further interest and discussion around professional curiosity using different lenses. So we had a session earlier in the year about SUDIs. This is the second webinar we've had about suicide, and as Nicola said earlier, we're running a series of roundtable events as well, where you're able to discuss issues in a little bit more detail. We have all the information on our website, on the Surrey Safeguarding Children Partnership website. You can also sign up there, and I think my colleague Liz, yes, she just put the links in the chat, which is really helpful. Liz, thank you. You can also sign up for a newsletter as well, so I would encourage you to keep the conversation going with us. Sign up to our newsletter, keep your eyes peeled for some more events. I think all of this learning is so invaluable, and just actually listening to people, giving examples, asking questions, sharing practice really helps. So thank you very much, everybody. Thank you for attending. Look forward to seeing you at the next one. And you've got 4 minutes back to go and have an earlier lunch. So thank you very much.